Sure, I'd be happy to. So, this study was a real world evidence study, and we're tackling the question of how is immunotherapy used in the setting of colorectal cancer in the real world post clinical trials, and what are the outcomes looking like in a real world population. And so, the major motivation behind this study was now that the approval of immunotherapy, specifically immune checkpoint inhibitors, in colorectal cancer has been available for a number of years. We wanted to follow up on the clinical trials in a real world setting to determine if the findings hold up, if there are any differences in what we see in a more unrestricted patient population, because as clinical trials are entirely the gold standard, there are very strict inclusion and exclusion criteria. And some of those criteria make it so that they don't entirely reflect the general patient population where the therapy ultimately will be used. So the underlying motivation of the work was to expand upon clinical trials, use real world data across the nation to understand practice patterns and outcomes of immunotherapy in the setting of metastatic colorectal cancer. Thank you for that question. So, microsatellite unstable colorectal cancers from clinical trials are the subset of colorectal cancers, about 10 to 15% of all colorectal cancers that responded well to immune checkpoint inhibitors in clinical trials. And in fact, patients with microsatellite stable tumors, or the other 85% of colorectal cancers, didn't respond well or didn't respond at all to immunotherapy in the original trials. So in terms of current practice patterns, this aligns with the clinical trial, that it aligns with um, the indications for immunotherapy in metastatic colorectal cancer. So that in particular wasn't particularly surprising, but what did surprise us and actually enabled the downstream aspects of the study were the fact that there were several hundred patients who had microsatellite stable tumors across the nation who received immunotherapy, even though that wasn't the indication following the clinical trial. So that allowed us to have a number of patients to look at um, their outcomes from in a real world setting, and that was a little bit surprising to us, but it also enabled the rest of the work. That's a great question, and I don't know is the true answer. Um, so these were patients who received it early in their treatment course or in an earlier line of therapy. We don't know at this point exactly why that's the case, but if they are, in my opinion, microsatellite, if they have microsatellite unstable tumors that have a high neoantigen burden, tumor mutational burden, and neoantigen load, and have a strong immune response, that they have the opportunity to respond to these therapies really at any point, but they're kind of primed and ready earlier in their disease course. So this was probably the most exciting and probably surprising finding of the whole study. And so 12.3% seems low, but it was way higher than what we anticipated based on clinical trials where there was essentially no response. So if you think about it, 12.3% of the majority, so 85% or so of colorectal cancers are microsatellite stable. That's still a really substantive segment of the colorectal cancer patient population. So we were super surprised to see this. And really, this is an active area of research in our lab and many groups across the country to figure out how do we identify these patients with microsatellite stable tumors who still may be responsive to immunotherapy and that aren't, clinically indicated to receive this really novel advanced therapy that works really well in a subset of patients. So it's hard to say how or why this happened. Although we did see in the study that patients with microsatellite stable disease who received antibiotics, who had higher albumin levels, and some other factors were more likely to respond than other patients with MSS tumors. So it may be factors related to the microbiome. Um, So we don't really know why this is happening, but was really exciting to see that there was a subgroup response and to set us off on a biomarker mission to figure out what are some of the factors that might help us predict who those patients would be. So in the study, we saw a comparison between patients who received immunotherapy and those who received chemotherapy, particularly in first line, and we also looked at later lines. And as compared to clinical trials, the real world data really reinforced what came out of the original trials, which is really important, even though it's not different. It's really important to show that there is, increased acceptability and efficacy in a larger patient population. And this was true particularly in patients with MSI high cancers, which is not a surprise, but it was great to see that consistency. In microsatellite stable tumors, still there wasn't really a noticeable difference between receipt of immunotherapy versus other, standard chemotherapy options, which is not surprising. It was in the subgroup of patients that again we have to figure out who exactly they are, and this data set had a limitation that we didn't have extensive genomic or molecular data on these individuals to really dig in and try to figure out other characteristics of their tumors. But those are the ones where the jury is out, if you will, and we're trying to figure out who those patients are. Is it a substantive set, and can they be predicted in such a way that there may be an opportunity for expansion for these patients, like as you said, have fewer options. Thanks for that question. So I think there's a real opportunity, and this is within our group, our institution, and the field in general, for a few different avenues. One active area of research is, how do we boost the immune response in patients with microsatellite disease to make them responsive to immunotherapy? But our study showed that there already is a subset of patients with microsatellite stable tumors who may respond even without these methods to try to boost the immune response. So there is an opportunity not only in the clinical trial space for expansion and priming and boosting the immune response in these patients, but also could we find a stratification biomarker that would allow us to enable a clinical trial comparing patients or trying to navigate patients with microsatellite stable disease to immunotherapy for those who are most likely to benefit. So one of the other things that we've been working on in parallel has been focused on tumor infiltrating lymphocytes or T cells in the immune microenvironment in large population-based studies. And in parallel work, we were able to show that a subset of microsatellite stable tumors actually has high T cell infiltration, which is a good prognostic indicator and a predictive factor for response to immunotherapy. So this is an avenue that we're trying to explore and determine if, as part of this prediction model, we could incorporate information about T cells that are already present in the tumor microenvironment, along with other features, to be able to identify subgroups of patients who might be eligible for future investigator-initiated clinical trials.